Good afternoon, everyone. Just making sure, Miss Sullivan, that our video and audio are working and everybody can hear and see the way they need to.
Good afternoon. We can hear you, Chair Etchart.
Thank you very much, Director Brereton. So we'll go ahead and call this meeting to order. This is a meeting with a presentation from the DPHHS regarding the RHTP. And so I don't think we need to do a roll call. Miss Sullivan, do we need to do a roll call? Nope. All right. Director Brereton, take it away.
Thank you, Madam Chair. And before we get started, Madam Chair, would you mind just outlining your vision for today's subcommittee meeting? I think we're all on the same page, but want to ensure that we're meeting your goals and needs.
Thank you for that question. So what we're looking for is how the licensing task force can help with any of your implementations of the RHTP and how it relates going forward. And then I will also ask Commissioner Swanson to weigh in on that, but also Director Brereton, we're looking to make sure that you have the tools that you need to work on that first plank with the hiring mandates and the hiring suggestions and increase with RHTP and DPHHS, working with DLI, making sure that we're going forward and you have the tools you need. And also, I think we're looking for some clarity to make sure, see where you are going forward, where you are in that process, what we can do to help.
That sounds great. And I think we're very much aligned. So with that, Aaron, let's go ahead and bring up the DPHHS DLI presentation and we can get started. Commissioner Swanson, I see you're online as well. Anything else to add before we begin?
Nope, take it away. Thank you, Director.
Okay. Good to see everyone. I think several healthcare subcommittee meetings ago, we had talked about a need to present on the department's Rural Health Transformation Program, commonly referred to as the RHTP, primarily, as the chair mentioned, to ensure that some of the policy commitments that were made in DPHHS's Rural Health Transformation Program plan were on this group's radar, and ultimately, if any action is required in the form of regulatory or legislative changes, that's something we as a subcommittee are bringing to the full task force for awareness and consideration, and want to ensure that these things or action items are also included in the task force's overall broad work plan that will be presented to the governor at some point, or at least used to inform the final recommendations to Governor Gianforte. So we can go to the next slide, Aaron. So three core components of our presentation today. We'll start with an overview of the Rural Health Transformation Program. As I look around the Zoom boxes here or the membership of the subcommittee, I think the vast majority of you are familiar with RHTP at this time. You've likely heard the department present on the program before various legislative committees, interim committees, as well as in different forums. But for those of you who are unfamiliar with the program, we'll spend just a few minutes highlighting what it is and what we're hoping to accomplish as a state over a 5-year period. Commissioner Swanson and her team will then take the lead on presenting to you on Rural Health Transformation Program Initiative 1, which is centered on the healthcare workforce. So I think DLI has perhaps 3 or 4 slides. And then I will close out with an overview of those policy commitments that I referred to earlier, that again are very important for this healthcare committee or subcommittee to be aware of at this time as it relates to the task force's overall work. Next slide. So the Montana Rural Health Transformation Program, I mentioned earlier, it's a 5-year federal program. All states and the District of Columbia were given the opportunity to apply for this funding that Congress made available to us. Many of you know that it was a sprint. DPHHS had roughly 6 weeks to pull together the application. We did that successfully. We got our application into the federal government by the end of calendar year 2025. And ultimately, the goal of Montana's plan is to support Montana's rural healthcare providers in delivering sustainable, high-quality care and ensuring access for those in need of services. Next slide. In the state of Montana's plan, commitments were made for 5 different initiatives. And I think it's important to note that these initiatives generally cannot be changed. So once they go into the plan application that was submitted to CMS again in late 2025, the state has some authority to modify budgets, to restructure how we're implementing some of these initiatives. But what you see here is what the state of Montana is committed to over that 5-year period. While the department has a phenomenal, outstanding relationship with this CMS, they have been pretty clear with us that they're not going to be super flexible if we were to say, hey, we want to take an entirely different approach to one of the sub-initiatives under Initiative 3. That's probably off the table, but we do have some discretion and authority again to tweak the sub-initiative in that case, or change how we want to implement the program and move some money around as well. So Montana's year 1 award, it's pretty incredible. It totaled $233 million to support the 5 core initiatives included in our plan. So you can see those on the slide. That's initiative number 1, which is developing workforce through recruitment, training, and retention, of course, referring to the healthcare workforce. And that's also the initiative that Department of Labor and Industry is taking the lead on in strong partnership with DPHHS. Initiative number 2 is ensuring rural facility sustainability and access through partnerships and restructuring. Madam Chair, members of the subcommittee, I am somewhat limited in what I can share today on that particular initiative, as we have active procurements for Initiative 2 right now. But that Initiative 2 is commonly referred to as the Rural Health Center of Excellence, or the Rural Health COE, which, again, many of you on the line are likely familiar with, or you've heard us mention Rural Health COE before in different forums. Initiative number 3 is launching innovative care delivery and payment models. Initiative number 4 is investing in community health and preventive infrastructure. And then initiative number 5 is focused on technology primarily. So that's developing and deploying modern healthcare technologies to guide rural health interventions. Next slide. We presented this for those of you who attended the first Stakeholder Advisory Committee meeting in Bozeman back in January. We presented this then, but wanted to spend a minute or two on the dedicated Rural Health Transformation Program unit that DPHHS is in the process of building out. So the way that we've structured the governance of the Rural Health Transformation Program is as follows. You can see up top there in that organizational chart or structure that there's a DPHHS Rural Health Transformation Program Steering Committee comprised of agency leaders, including our Tribal Relations Manager here at DPHHS. Right below that steering committee is the Rural Health Transformation Program Director, and that is a position that DPHHS is actively recruiting for. If any of you know of interested candidates, please send me an email or refer those individuals to us. We're eager to get that position filled. At the moment, Jean Hermanson, our Deputy Medicaid Director at the department, is serving as the interim or acting RHTP Director, but again, need somebody to step into that role full-time. Underneath the Rural Health Transformation Program Director are a number of program officers for each of the 5 initiatives that I just highlighted. If you look at initiative number 1, it is a DLI liaison as opposed to a program officer. but that DLI liaison will ultimately serve as a program officer for those Initiative 1 projects or activities being led by the Department of Labor and Industry. We have successfully hired program officers for Initiative number 4 and Initiative number 5. We also recently onboarded our Rural Health Transformation Program communications officer. I had an opportunity to meet those 3 staff yesterday during our weekly steering committee meeting. Looking over in that far right column, you'll see a number of other RHTP positions or staffers who will support the program over the 5-year period and potentially into a year 6 as we start to wrap up the program and the federal award at the end of the funding period. Many of these positions are operational in nature. So you have a grants manager, a budget analyst, a compliance officer. I just mentioned the communications officer who will report to the DPHHS comms director. We have 2 additional tribal liaisons that we're recruiting for. We have a data engineer, a research data scientist, a data visualization specialist, and then 2 community liaisons who will likely be serving Eastern and Western Montana. Key takeaway here for the subcommittee is we're building quite a team to support this program over that 5-year period. And again, if you know of anybody who might be interested in these positions, please don't hesitate to send them our way. The 2 boxes in the far right, and then we'll move on to the next slide. So I mentioned the Stakeholder Advisory Committee earlier. This is a non-decision-making consultative body representing communities and stakeholders. And we have roughly 30 stakeholder member groups or representatives on that Stakeholder Advisory Committee. That Stakeholder Advisory Committee meets 2 times per year, and the Montana State University Office of Rural Health is DPHHS's primary partner in leading those Stakeholder Advisory Committee meetings. We also have a Montana Rural Health Center of Excellence Governing Board or Governance Board. We are in the process of rolling out details associated with that board, including how to apply to the board if you want to serve on it. But again, Madam Chair, I'm somewhat limited in what I can share due to those active Initiative 2 procurements. Next slide. Alluded to this earlier. Again, just want to do a bit of a victory lap here on behalf of the governor. So we did receive approximately $233 million for our year 1 award from the federal government. Montana did rank 4th nationally behind Texas, Alaska, and California. Our neighboring states, including Wyoming, North Dakota, South Dakota, and Idaho, all received less funding than Montana. And as I mentioned earlier, too, the award is allocated for those 5 core initiatives that were included in Montana's plan application, with no ability to add or remove those initiatives. Next slide. Scoring, always a fun topic. So this is largely based on the CMS NOFO or Notice of Funding Opportunity that states were provided. So the key takeaway here is that CMS's scoring of Montana's application or all states' application was based on 3 factors. So factor number 1 is initiative. So those are points awarded based on a qualitative assessment of the programmatic initiatives or commitments that we were making in our application or planning to implement over the 5-year period. Factor number 2 are state policy actions, which we'll cover a bit later, very relevant for this subcommittee and the overall task force. So these are points awarded based on current state policy and then proposed policy action committed to in the application, as well as subsequent follow through to actually make those policy changes that we said we would in our application. So according to CMS for the year 1 award, states received credit for state policy actions in effect at the time of the application, as well as credit for some of the policy commitments that were made in the application. I also wanted to point out that CMS scored all policy commitments except for B2 and B4. B4, which is the nutrition CME requirement for physicians, is especially relevant for this group. And again, we'll come back to that later in our presentation. And then additional points for these various policy commitments may be awarded by reaching certain milestones over the 5-year award period. Lastly, CMS considered data-driven metrics as the third scoring factor. So that was based on certain data quality metrics evaluated by CMS at the time of the Rural Health Transformation Program application. And those data elements or data factors were outlined in the notice of funding opportunity. Next slide. Stakeholder consultation. Many of you on this call were excellent partners to the department when we were rapidly crafting our Rural Health Transformation Program application back in fall, winter of 2025. So during the plan development, the department worked very diligently to conduct a number of one-on-one consultations with certain Montana hospitals, tribes, and then just over 20 additional healthcare stakeholders here in the state. We also hosted a webinar that had nearly 900 registrants, and we reviewed more than 300 RFI responses following 2 different RFI processes or tracks. And then we will continue to consult stakeholders and gather input from all of you and your organizations, which would include, as a stakeholder, this subcommittee here, as well as the overall licensing reform task force. So the stakeholder consultation has been very, very critical to our work. Because the timelines were so tight, we did our best to engage as many stakeholders or relevant stakeholders as possible. But I will admit that there's more work to do on this front, and the department is very, very committed to continuing those conversations, especially with stakeholders and organizations that we may have missed during the plan application period. Next slide. And that leads us to Initiative 1. So with that, Madam Chair, I will hand it over to Commissioner Swanson, and then it'll come back to me.
Thank you, Director. Good morning, everyone. I don't know who's controlling the slides. Can we move on to the next one, please? Thank you. So like Director Brereton said, the Department of Labor is working to formalize an agreement with DPHHS to work in partnership with them, but to lead Initiative 1, the Workforce Initiative for Rural Health Transformation. As it's currently designed, it is broken into 3 sub-initiatives. You'll see an overview of each here, but I'll go a little bit more in detail for you as to what we're planning. As of today, just over $20 million is appropriated annually to the Workforce Initiative. The first sub-initiative is designed to expand rural healthcare workforce through training and recruitment. That's approximately $15 million a year. It includes a dedicated talent attraction and direct professional recruitment effort. It includes middle and high school career exploration programs through organizations like HOSA and registered pre-apprenticeship in sector-based pathways, leading our young people into meaningful healthcare careers with ladderable and stackable skills and credentials along the way. It includes additional AHEC pipeline program expansion, and it includes a heavy emphasis on registered apprenticeship for healthcare careers with incentives for the mentors and funding available for the related instruction. In apprenticeship, related instruction is the college curriculum or the other coursework needed to obtain those healthcare credentials and licenses. Many healthcare positions, including from CNAs to LPNs to registered nurses, are all apprenticeable in Montana in a laddered environment. There's 26 pathways through healthcare through apprenticeship, and Initiative 1 has a heavy emphasis on apprenticeship as a pathway to success. There's also short-term and non-credit credential programs targeted directly at our HelpLink participants in Montana. There's funding for up to 700 HelpLink participants. Those are the Montanans that are participating as adults in the Medicaid expansion population. And there's funding in this initiative to serve up to 700 per year, directing them through non-credit degree programs into meaningful healthcare careers with employers around Montana. And there's additional education and training programs to address priority occupations that we'll go through in a moment. Sub-initiative 1.2 is approximately $3.9 million to enhance rural clinical training capacity in Montana. That includes expanding slots in existing residency programs around the state, developing and expanding rural training tracks for advanced practice providers, physicians, and others. It includes direct preceptor and apprentice mentor training and support, and it includes a feasibility analysis on new residency or fellowship programs that may be needed in Montana in future years. And Sub-Initiative 1.3 is directly tied to upskilling and retaining rural healthcare workers in Montana. That's approximately $1.2 million a year as of now. It includes supportive services to reduce barriers to work, including relocation incentives. It's upskilling programs, whether that's tools like AI to reduce healthcare worker burnout, upskilling professionals, or addressing skills needed for specific rural practice environments. And it includes a number of retention strategies, whether that's peer networks, consult and referral support, or others that are identified by healthcare employers and practitioners that they may need to be successful practicing in rural environments. We are working diligently with Mr. Brereton and his colleagues at DPHHS to finalize that MOU with the full funding and metrics, but we're moving quickly and hope to get started soon. We will be deploying Initiative 1.2 in partnership with stakeholders around Montana, including the Graduate Medical Education Council. And Initiatives 1.1 and 1.3 will really be focused on pilot communities around Montana, getting started in year one. As I'm sure the director will share, our first annual report on RHTP is due in August, so it's a very compressed year. So we'll be working on a shorter timeline for this first year with some pilot communities. We could go on to the next slide, please. The metrics in Initiative 1 are very specific, related to our current baseline of skilled licensed workers in Montana and the annual target increases. You'll see that we're currently committing to measure growth in APRNs, in physicians, in registered nurses, dental hygienists, emergency care providers, and PAs across the state. And there's a separate metric around the separation rate in healthcare in our specific 46 rural counties, continuing to work towards retention and upskilling of those healthcare workers. Next slide, please. So in year one, it is a compressed year. The first report will be due August 30th. The specific year one tasks that we've committed to in each of those sub-initiatives are identified here. We're excited to get to work. We've got a team hired here at the Department of Labor that are ready and willing, and we'll be in touch with all of you very soon. Once that MOU is signed, we're ready to get to work. We've started meeting with healthcare employers around the state, and we're looking forward to launching our year one initiative. These are the example activities that we have committed to completing between now and August 30th of this year, and I'm confident that with all of your help, we can do that. Next slide, please. All right, back to you, Director. Happy to answer any questions at the end today about the Initiative 1 Workforce Initiative.
Thank you. All right, next slide. Policy commitments. So in the federal or CMS Notice of Funding Opportunity for the program, CMS identified 8 total policy actions that states could commit to in order to draw down more federal funding throughout the 5-year award period. As part of the application, states were required to describe their current policies for each of these actions as part of the technical scoring criteria calculations that I covered in an earlier slide. During the application process, again, about a month and a half long period, the department engaged the governor's policy team to initiate some of these discussions across the various policy action areas. The governor's office generally indicated support pending stakeholder alignment across 5 different policy action areas that DPHHS included in our final application for the state of Montana. So number 1 is enacting a SNAP food restriction waiver. Number 2 is introducing a nutrition CE requirement or CME requirement for physicians. Number 3 is implementing an EMS compact. Number four is formally recognizing what we understand to be existing scope of practice for dental hygienists operating under a limited access permit or an LAP. And then lastly, reimbursing through Medicaid additional remote care services. So primary examples there are store and forward reimbursement or services, as well as reimbursement for remote patient monitoring. The department then continued to consult with a handful of relevant stakeholders to assess the requirements and their interest in advancing these various policy commitments or actions. Of the 5 policy commitments that are included in our plan, as reflected on this slide, DPHHS determined that implementing a SNAP food restrictions waiver, which is in motion now, as well as expanding Medicaid reimbursement for some of those remote care services, are achievable without additional statutory changes or any real policy input from the legislature. So the Medicaid reimbursement will, of course, have some implications for our DPHHS budget and our Medicaid caseload. We've started to have that conversation with our Section B subcommittee and expect potentially an EPP request to that effect pending OBPP final approval. But ultimately, for these two policy commitments, DPHHS will serve as the direct implementer. We can do this on our own. And then we believe that 3 of the 5 policy commitments will likely require action from the Licensing Reform Task Force and your support as a subcommittee. Next slide. So the three policy commitments or action areas that will require support from the task force are highlighted there in yellow. So starting with the nutrition CME requirement, we absolutely acknowledge the need to work closely with the Department of Labor and Industry and the Board of Medical Examiners to get this across the finish line. The department did provide public comment about this policy action at the Board of Medical Examiners meeting on October 23rd, 2025. And then in partnership with DLI, we intend to present again to the board at their late April meeting coming up here in just a few weeks. Since then, or I guess in advance of the Board of Medical Examiners meeting in late April, we have continued to seek DLI's input on implementation strategy. DLI rightfully has been very honest with us. And again, we acknowledge that BOME is key here. And we have some work to do with them and some explaining to do to relevant stakeholders. So looking forward to some of those conversations. The Department of Labor and Industry has also raised that establishing this requirement may require some sort of audit capacity, which may require additional support in the form of an FTE or a position budgeted. The department acknowledges that, and we absolutely could use some of the Rural Health Transformation Program admin funding to support an FTE to that effect and as required. Our partners at DLI have also indicated that this may require either an arm change from the Board of Medical Examiners or legislation to fully implement the requirement. So again, Madam Chair, we are seeking both the subcommittees and task forces support with this policy commitment and respectfully request that it be contemplated as part of the broader licensing reform task force work plan.
Noted. Thank you, Director.
Yep. Next, we'll move into EMS licensure. So for EMS licensure compact adoption, DPHHS recognizes that DLI may have already brought this policy action to the task force's attention, and we ultimately want to reiterate our strong support for the compact and again request that the task force include the EMS licensure compact in its work plan as legislation will be required. Madam Chair, we're also tracking CFHHS's work in the EMS space and believe that this policy commitment is is in many ways complementary to the work that your interim committee is doing as we speak. I am joined by Sherry Graham, who's an EMS subject matter expert at DPHHS, to answer some of the questions that the subcommittee may have regarding the kind of the overall direction for Montana's EMS system. But I did want to flag for you all that under our Rural Health Transformation Program application, we did allocate funding for two categories or types of EMS programs. So under Initiative 1, led by DLI, DPHHS will provide DLI, and this is in summary, but will provide DLI with the funding to support training for emergency care providers, including endorsements for community integrated health and community paramedicine, as some of those trainees are or emergency care providers are interested. And then under Initiative 3, later in the Rural Health Transformation Program plan, in particular under Sub-Initiative 3.2, DPHHS elected to fund EMS modernization efforts, Madam Chair, that we've discussed with you and CFHHS before, including infrastructure grants, pre-hospital blood pilot programs, assessing the need for a new emergency dispatch system for the state of Montana, and then again, looking at community integrated health and community paramedicine systems integration, ultimately separate but complementary to the workforce efforts under Initiative 1 that I highlighted above. And before I move on from EMS, Amanda or Sherry, did you have anything else to add there?
So Shari is an attendee, so we'll need to be promoted to a panelist to be able to speak.
Aaron, do you see any hand raised or any requests from Sherry?
Good afternoon.
Oh,
Yeah, I'm just here to answer any questions that you may have about the compact. I've been involved with the compact for several years since its inception, really, just as far as having knowledge of it and the work that they've done previously in Montana, which has been limited. But any questions that you might have, I'll do my best to answer them.
right. We'll move on to scope of practice. So thanks to our partners at DLI, as well as oral health stakeholders, we well understand some of the longstanding dynamics associated with expanding dental hygienist scope of practice in the state of Montana. During the RHTP application process, DPHHS consulted closely with the Montana Dental Association and some other dental representatives to clarify which, if any, of the expanded scope of practice commitments might be supported by MDA. In order to receive full points or maximum funding for this particular policy factor, Montana would need to commit to allowing dental hygienists to perform one of three tasks. So that those tasks include diagnosis, supervision of dental assistants, and treatment planning. As of just yesterday afternoon, DPHHS consulted with the Dental Association again to further discuss implications for the scope of practice policy commitment included in our application. And as we understand it, dental hygienists under or operating under limited access permits are allowed to treat and diagnose without dental supervision, but would welcome that discussion with this group. And Webb, I wanted to turn it over to you for any additional comments before we move on to the next category.
And I'll have to find my mute button. All right, am I there? Can you hear?
Yep, we can hear you.
Okay. Yeah, no, appreciate that, Director Barrington. And I think some of the conversation that we had yesterday was what are some of the allowed practices right now under that limited access permit. And as some of you folks know, House Bill, I think House Bill 321 runs in my mind, expanded the limited access permit in the last session. So I think we're in conversation about how does that implement the potential for meeting at least one, if not two, of these requirements for that level of support. So appreciate the director bringing that forward. And yeah, I think we're definitely looking forward to having that continued discussion as we go forth.
Thanks, Webb. And we're absolutely committed to continuing our engagement, not only with you and the Dental Association, but also the Montana Dental Hygienists Association and CMS. We have a bit more time to figure this one out. But I also wanted to be clear, Madam Chair, and members of the subcommittee, that it is absolutely not our intent to expand dental hygienist scope of practice, but rather secure federal funding from CMS for current practice under the limited access permit. So we expect that this policy commitment may require some form of task force support in the future, but the exact type of support is to be determined pending some of those continued discussions with stakeholders and CMS. Next slide. All right, there were 3 other RHTP policy commitments that we wanted to bring to the subcommittee's attention, as they may require some collaboration in the future or support from the overall task force. But at this time, DPHHS does not believe that any formal action will be required as it relates to the work plan. So sub-initiative 3.3 focuses on increasing access to care through pharmacists. Tony, welcome your thoughts on this one later if you want to weigh in here. And we appreciated some of those discussions that we had with the association when we were developing the plan. Wanted to clarify for the subcommittee that, again, DPHHS is not seeking to expand in any way, shape, or form pharmacist scope of practice beyond what is already authorized in the state of Montana. Rather, Rural Health Transformation Program funding is being used to, or will be used to, cover startup costs associated with the purchasing of medical equipment, including rapid near-patient diagnostic tests for screening and monitoring, as well as infrastructure improvements for pharmacies in rural communities. So from our perspective, the RHTP funds that we've allocated under sub-initiative 3.3 will build on the great work that was done during the 2023 and 2025 legislative sessions regarding pharmacists, and ultimately further enable pharmacists to take advantage of the enacted legislation. Tony, anything to add at this time?
Thank you, Director. We are excited and appreciate the opportunity to show what we can do. We have had a lot of interest from our pharmacies in this, and look forward to working with you guys and rolling this out.
Thank you. Appreciate the continued partnership. Moving on to initiative number 4. So sub-initiative 4.1 covers school-based care or school-based healthcare services. Through our Rural Health Transformation Program plan, the department seeks to increase access to care through school-based sites, and we intend to use RHTP funds to build on the success of today over 80 existing sites and promote the offering of behavioral, primary, and dental care at many of those sites. We do understand from our partners at DLI that the inclusion of dental hygienists, LAP, in school-based settings may be a topic of contention, and welcome the subcommittee's input on that front. We also recognize that this may require multiple licensing boards to consider either Practice Act or arm changes to accommodate the school-based care models that are contemplated in our Rural Health Transformation Program plan. So, Madam Chair, DPHHS is seeking the subcommittees and the licensing task force's input on this approach. And if the subcommittee and/or task force determines that Practice Act and/or ARM changes are required to help implement this recommendation or this sub-initiative, then we would respectfully request that the task force include this as part of its overall or broader work plan. Last but not least, CHAP. So the Tribal Community Health Aid Program, in addition to community health workers or CHWs. So in our plan, DPHHS allocated funds to enable CHAP systems and educational programs to be developed. Right now, that program sits with DPHHS, although as part of the ongoing MOU negotiations that Commissioner Swanson alluded to earlier, DPHHS and DLI are still determining whether the CHAP program may need to formally live with DLI as part of Initiative 1 or in relation to Initiative 1. I wanted to take an opportunity to clarify that community health aides as part of CHAP or that program do not require equivalent licensure by the state. So no additional involvement is required or will be required from the licensing task force at this time. Furthermore, community health aides under CHAP are distinct from community health workers in non-tribal settings. So DPHHS is very, very supportive of DLI continuing to fund community health workers through its other workforce programs separate from CHAP, including our Rural Health Transformation Program, HelpLink sub-initiative, which is part of Initiative 1, led by DLI. So, Madam Chair, that concludes our formal presentation. I hope that was helpful. And I'll turn it back to you and the Vice Chair.
Thank you, Director Brereton. Very much appreciate that. So just want to make sure, Commissioner Swanson, do you have anything else to add? I know we had your portion of the slides there. I just want to make sure before we move on to questions from the committee that you include anything you like, please.
Thanks, Chair Etchart. I don't have anything else to add at this time, but happy to be available for questions. I'm sure the committee has plenty.
Thank you very much, Commissioner Swanson and Director Brereton. At this time, I'd like to open it up to questions from the committee. And I see Senator Small. And yes, I know you're a retired senator, but still, that's your title. Senator Small, would you like to go ahead, please?
Yes. Actually, I have several questions. And I've been kind of overloaded with this presentation today because I understand the absolute insanely complex situation this is, because I've passed a lot of the legislation involved in some of this, and it's massive and extraordinarily difficult to get done. But so I guess my first question for Director Barrington is, what all is allocated to, say, school-based care? Was it dental only? And if I was going through the slideshow correctly and reading, I mean, was that primarily based on just doing the presidential fitness deal again, or what are we looking at there? How much money can go to school-based care?
Madam Chair and Jason, are you asking for the budget that we allocated in the Rural Health Transformation Program plan for school-based care? I also heard reference to the presidential fitness tests.
Yeah, and sorry, I probably asked that question funny. Yeah, no, I would like to know what the budget is and what were the precursors other than changing, basically putting altering what's allowed with the dental and the presidential fitness award stuff. What needed change to get all the money allocated to basically school-based care?
So I'll start by clarifying maybe that Montana did not commit to implementing the presidential fitness test. So
Okay.
so you likely saw on the slide that that was one of those policy factors offered by CMS. We had a few conversations with the governor's policy team as well as OPI and ultimately elected to decline to make that commitment just primarily due to concerns from OPI about schools statewide and districts statewide being open to adopting the presidential fitness test. And then as far as your question on school-based care budget, I don't have that exact budget figure before me, but Gene Hermanson is on the call. Gene, do you happen to have that line item available?
Yeah. Good afternoon, Chair, members of the committee. Gene Hermanson. In our year one budget, we have $5 million allocated to the school-based services initiative. And then assuming that continued funding throughout the 5-year period, we have approximately 27 million anticipated for that.
Okay, thank you. And then if you don't mind, I have follow-up.
Follow up, please, Senator. Thank you.
Thank you. So I guess my second question was, we went through the discussion of compacts, and I think you had 4 or 5 that were kind of listed there. I didn't take the greatest of notes, but so in that section, what compacts need accepted to be able to receive the money, and how many of them are actually in motion already? And I mean in motion as in, have the boards, have they had preliminary discussions? What is this going to catch people in the dark? What are we kind of
No,
looking at there?
no. So it's only the EMS compact that we need to advance in order to secure the maximum award associated with this policy factor. So on the slide that I presented, I think we took that directly from the federal notice of funding opportunity, but it did provide Jason several examples of compacts that are acceptable to CMS in order to secure the funding.
Mhm.
But for Montana, it's only the EMS compact that would need to be enacted and implemented. That's the only commitment that we made.
Okay, great clarification. Thank you for that.
Yeah.
I was pretty scared looking at that list. I was like, oh my
Yeah.
God.
Otherwise, I mean, from CMS's standpoint, Montana is doing quite well in the compact arena. So EMS only.
Oh, wonderful. And then just I had one last comment. I was involved in the initial passing of CHAP. Gosh, I don't know, that had been around 5, 6 years ago now. And that was entirely more difficult to pass than Medicaid expansion. And I'll just make one statement here. I think it's pretty wise to leave that out of the purvey of DPHHS and leave it in basically in DLI, because licensure obviously is going to be the big issue there. A lot of people are going to start complaining, even though it's irrelevant to anybody but IHS. So,
Mhm.
thank you for that. I think that's going to work out better. That's all I
Yeah,
have.
we're excited about implementing CHAP and separately on the Medicaid side, continue to have productive discussions with tribal health stakeholders on a potential Medicaid state plan amendment or SPA to support CHAP in the future. But our first step is launching CHAP in Montana, which, and I know I'm preaching to the choir, it's very, very complex. Before we move on from CHAP, Amanda, you've really served as our lead with that program. I was wondering if you have anything else to add in response to Senator Small's question or comment.
Sure. I would say that we really appreciate the sort of tri-fold nature of setting up a chat program, understanding that it requires an accreditation board that's controlled by the tribes. Because as you know well, CHAP is about allowing tribes to establish their own needs and set their own standards, which is why the licensing is not under DLI, but is separate. And then also the second pillar is about helping tribal health clinics establish their workflows and thinking about how they integrate this new provider into their healthcare delivery system. And then the third is the workforce and training. And we are very excited to partner with DLI and use their help in reaching tribal colleges to set up those programs there. I'm happy to answer any other questions, but that's the high level.
Thank you very much. So we will go to the next hand raised. I think Mr. Brown, I believe your hand was raised next. So we'll go ahead and go to you. And then I do see the other hands raised. Thank you.
Thanks, Chair Etchart, and appreciate the opportunity again to jump in here. And I'll try to be quick because I know I already talked once too. But I don't know if it's a question for Commissioner Swanson or more of a comment, but we do appreciate the opportunity that dental assistants do have a apprenticeable pathway now. And we just have not seen the take up on that at this point that I think we could see and need to see overall. So again, I guess my question would be how do we do that? You and I probably need to have a sit down more offline and with other staff to do that. But I think it's a tremendous pathway, not only to get more dental assistants into practices, but also potentially a pathway to a certified dental assistant and potentially even to hygiene or dentistry. We've had dental assistants who have gone to all three levels. So that would be one question. Again, just touching back to Director Brereton and talking about House Bill 321 and the LAP, especially because it was focused in the schools in Montana for the specific changes we made in that bill and our cooperation with the Hygiene Association to, put, I guess, the standards around that, which really do focus on rural health as well. I do think that's, again, a tremendous area of cooperation for us to move forward with some discussions overall. And then just a side note on the EMS, I actually served as a volunteer EMT back in Sanders County 100 years ago. So would love to see some, potential of moving that forward as well. But yeah, I don't know, Commissioner, if you want any comment on that, but thank you. Appreciate that, Chair.
Thanks, Webb. We too are very excited about the opportunity for registered apprenticeship and those stackable, ladderable opportunities in the dental space. Montana was one of the first 2 states in the country to get approval to do a dental assistant registered apprenticeship. But registered apprenticeship is a partnership. The department can get it approved and get it in place, but every apprenticeship requires a partnership between a willing apprentice, an aspiring dental assistant in this case, and a willing employer sponsor. And so we absolutely would love your help doing that because we need those sponsors. In Montana, a sponsor for a dental assistant apprentice can be a dental hygienist or it can be a dentist. Both can be an approved sponsor. And we are happy to work with any employer that wants to stand that up. And we're so excited about the opportunities that rural health transformation poses in that stackable career ladder. We're actively working with stakeholders from around the country right now to get dental hygiene approved as a registered apprenticeship through their accrediting body too. Lots of steps to be passed, lots of states and stakeholders are involved, but we're really convinced that that's going to be a meaningful pathway for aspiring professionals in rural communities around Montana to learn and earn in their communities without having to stop working, move to a campus, and get a dental hygiene education. Lots of moving pieces, but in short, Webb, this is a great opportunity for us to leverage rural health transformation funding to move that ball, and we'd love to keep working with you and the association and the Dental Hygiene Association to move this forward.
Excellent. Thank you, Commissioner Swanson. Mr. Brown, that covers your questions. Yes, sir?
Absolutely. Thank you, Chair.
Thank you, sir. Let's move on to Ms. McCauley.
Hi, thank you, Chair Etchart. I was wanting to expand on the question offered by Senator Small about the scope of practice and the licensure compacts. The way I understood the presentation is we got a large allocation in part because our current advancements in those areas. And it looks like we've only committed to license expansion or compact for EMS, and then the scope of practice for a dental hygienist. As long as it doesn't preclude, prohibit, slow down our progress for those initiatives, would it also be prudent to continue to work towards compacts on those other degrees and extend scope of practice in those other areas where it makes sense?
That's a good question. I would defer to DLI. I mean, they know a lot more about the compact structures, the history, the dynamics than we do. But for our year one award, you're correct. I mean, the funding was provided to DPHHS for making that EMS compact policy commitment alone. But in the grand scheme of things, when you're thinking about approximately $233 million for year one, it's a very, very small piece of that $233 million, that particular policy commitment. But Commissioner Swanson, did you have additional thoughts there?
Yeah, happy to, Director. There are a number of compacts that Montana participates in, and there are 7 more that we do not. I think I raised each of them by name at our very first meeting of the task force in Helena, encouraging this committee to come to some consensus on, with those outstanding compacts, which ones are we collectively committed to moving forward with and which ones are we not. I would encourage you to keep that as part of your discussions as we move into finalizing a work plan. There are a number that are available that we're not in, and I believe off the top of my head, 5 of those are in the healthcare category. So this is a great time for us to come together as stakeholders and decide which ones are appropriate to move forward for Montana or not, recognizing that anyone that we choose to enter will require legislation in the next session.
Thank you both. That does help a lot.
Ms. McCauley, does that end your questions?
Yes, thank you, Chair Etchart.
Thank you very much. We'll move to Dr. Brewer.
Thank you, Madam Chair and members of the committee. I am a family physician and I am here on behalf of the MMA. We just wanted to point out that the CME requirement in this for physicians specifically is a bit of a departure. We don't currently require specific types of CME, and moreover, some of our physician providers do not have direct patient care where nutrition information would be applicable. So I don't have a specific question. I just want to point out that this is a departure from previous requirements for physicians.
Yeah, thank you. And DPHHS owns this one. So we decided to put it in the plan. I mentioned that we came before the Board of Medical Examiners, I think back in October, and sought input, highlighted that it would likely be included in the state's Rural Health Transformation Program plan, but look forward to the continued discussion with the BOME on April 24th, I believe. And then I also think it's something that we should include, Aaron, at on the agenda for our upcoming healthcare subcommittee meeting next Friday. I think, as you asked me this morning, that would be one of those topics that we should spend some more time on as a group.
Nice.
With appropriate representatives, even if they're not on the healthcare subcommittee.
Ms. Hensley, please.
Thank you, Madam Chair. Director Brereton, I believe this is for you, but if not, feel free to kick it on over to Commissioner Swanson. I just need some clarity. I guess this is more the 20,000 foot level on specifically what mechanism you anticipate being used to get these dollars where they need to go. So, for example, I know that the Center for Excellence is going to be administering a huge chunk to advance primary care, and Department of Labor and Industry for 1.1 has the 20 million for recruitment and retention. The mechanism, is that going to be to pay the providers? Is it going to be in scholarships, loan repayment? What do you anticipate some of those mechanisms would be? And can you give me clarity around the sideboards on those? Like no brick and mortar facilities, no actual equipment, only training, things like that.
Thanks for the question, Jen. So again, I heard like several different questions in one. Are
That's
you
my
referring,
specialty. Yeah.
yes, are you referring to just can you narrow that down for me a bit?
Sure. Let's look specifically at the 20 million. I know that the final details are not
Yeah.
finalized, but I also know that some buckets aren't even going to be considered because they're outside of scope of the overall RHTP, no matter how creative folks get with describing the project. So can you tell me, absolutely none of these dollars will be spent on grants to purchase technology and independent practices or provider reimbursements for independent providers that are not affiliated with a hospital or a clinic that are just independently out there. Those sorts of lines in the sand that are off the table, or is creativity really rewarded here?
Are you referring though to the overall Rural Health Transformation Program year one budget, or is it a specific initiative or sub-initiative that you're asking about? Because it obviously depends on the program, the
Sure, thank
initiative
you.
or the
For
sub-initiative.
the later on, you and I can have lunch and chat about all of it, but for today, let's work on 1.1. Commissioner Swanson mentioned 1.1 for recruitment, retention, program expansion, expansion of apprenticeships, up to 700 people on Medicaid expansion, trained, et cetera. So in my mind, a program about recruiting, say, an optometrist in far eastern Montana would include grants for remote office setup and telehealth capabilities. But that would require purchase and procurement of actually equipment. So is that nuance worked out yet, or is it yet to be determined?
Commissioner.
I'm happy to take that one. Hello, Jen.
Hi.
In short, it's not quite worked out yet, but I can give you some framework around what we're currently discussing. We're in the final stages of finalizing the MOU with the scope of work and commitments with Director Brereton and his team. Once that's finalized, I can give you exact answers, but we're close. Specifically about the talent attraction and direct professional recruitment piece, that is currently budgeted at just over $1 million. And while I am so proud of the 677 people that work in this agency every day, they're so good at what we do. Recruiting licensed professionals to live and work in rural communities is not our strength. And so that initiative is going to be put out through public RFP to hire a firm who specializes in talent attraction with direct experience and a track record of placing professionals in Montana facilities. We are aiming to ensure that this is not a $1 million campaign of mailing really pretty pictures of Montana around the country. We want a vendor or a firm that has experience on the ground of actually placing people in Montana. So that will be going out through RFP. It's just over $1 million allocated to that talent attraction piece.
Just to follow up to that one question,
Yes,
and I think it'll answer others for me.
yes.
I know that you appreciate caution around spending all this transformation dollars on consultants, right? And yes, we've paid $1 million to a consultant firm to tell us where to blah, 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 right? And at the end of the day, we have no new providers. I know that that's not what you want. Having said that, if the consultancy comes back and says, quite frankly, you're not getting people in rural Montana because y'all aren't paying them enough, can those dollars then be spent to pay them enough?
There is not funding in this particular bucket for wage subsidies. This particular bucket is to do the actual talent attraction of a firm who specializes in recruiting and placing people in rural communities. We will do that in partnership with each of the healthcare employers. They will identify for us what are the exact positions, what is the license needed, what is the credential needed, And this firm will help us recruit and try to attract those people. That is one small piece of Initiative 1.1. If you recall, I said that is currently budgeted at $15 million. Just over 1 million of it is designated for this talent attraction firm to do the direct recruitment of licensed professionals from other states who currently hold a credential to move and live and work in our rural facilities. That is one piece of it. As far as the training and upskilling of Montanans, the dollars in Initiative 1.1 at the Department of Labor are directly attributable to the training costs for Montanans to reach skill, credential, or licensure. There is not budget for us assigned by our friends at DPHHS for systems, for facilities, for technology. The funding assigned to us is to directly deploy training, whether that's training to young people in our current high school settings or whether that's training to folks on the ground looking to upskill. The example I'll give you is maybe we have a current CNA or CMA that wants to upskill to an LPN or potentially to an RN. These dollars are attributable to directly paying for the cost of training. And then in Initiative 1.2, there is a direct budget to compensate the preceptors or the mentors that are helping with the additional supervision and training on the ground in these facilities.
And then do you anticipate an obligation request in exchange for the training? Say we train you up to become an RN and you've got to practice in these areas for the next X number of years?
I'm really glad you asked. There is a 5-page document from CMS that's hot off the press this week that I will ask Erin to send to the full committee so you can spend some time with it. But specifically, there is a 5-year service commitment required by CMS for anyone who receives a direct training investment with rural health transformation dollars. It is not specific to the license category or the skill that you are trained in. It is a specific commitment that you must work in rural healthcare in one of our rural counties designated by this program for 5 years. Now, there's a caveat there that we did get clarified last week with our friends at DPHHS from CMS. If you are in a residency or a rural track training rotation or a registered apprenticeship, your time in service during that starts your clock. That counts towards your 5 years.
Thank you. And one last final question, I'm sorry, and then I'll give it back. I know, Director Burton, that as of week before last, right, in front of Section B interim, you were still kind of talking about which model to use to define rural, urban, et cetera.
Mm-hmm.
Has that been determined?
Not yet.
Thank you.
Yep. Jen, before we move on, I also wanted to share with the subcommittee, in part in response to one of your questions, that DPHHS and DOA hosted an RHTP procurement summit several weeks ago. That is recorded, and I would encourage everyone on this call, in this group, or others to check that out. If you weren't part of it, you haven't already watched some of the presentations, hopefully that will explain how the money across all of the initiatives is going to start flowing.
Thank you, Director.
Thank you. Ms. Nearson?
Thank you. And if this was covered in the procurement webinar, I apologize. But for the commissioner, how will the money for training be determined, or how will it be distributed? Is that going to be grants, or if folks have a training program, did you guys already determine who will get that?
Yeah, that's a great question, Amy. It is not already determined. Quite simply, through the existing work of the Department of Labor, whether that's through our outreach teams like Registered Apprenticeship, whether that's through our teams at Montana Job Service, or through our work working directly with healthcare employers, critical access hospitals, FQHCs, and others, we will be working with them to identify actual individuals that need to be trained, and DLI will be paying for the cost of that training per individual. That's the only mechanism that we have to ensure that the 5-year service commitment is upheld, because we have to tie the funding to an individual. So those will not be block grants, if you will, out to institutions. They will be tied to direct individuals. We're pretty good at this. We do a lot of direct payment for training for thousands of Montanans every year. This will just be specific to those healthcare occupations that we're targeting for specific growth metrics in the overall RHTP commitments that our friends at DPHHS have established.
Ms. Nearson, does that finish your questions?
Yes, thank you.
Thank you. We'll move on to Mr. Longcake, please.
Yeah, hi, thank you. This is for Director Brereton. Thank you for the clarification and all the detail on the presentation so far. I think that helps provide some significant clarification on some of the bits and pieces that your team is working on. And I want to thank the commissioner for meeting with myself and the Dental Hygienists Association a couple weeks ago just to try to help, again, provide some clarity. I just wanted to offer up our services to you, Director. If there's another opportunity when you're meeting to discuss scope of practice or LAP opportunities, either myself or one of our board members would love to participate. They have a ton of expertise and live this every day and have some great examples where we could probably help bridge some of those gaps. So just wanted to offer up our services and appreciate the opportunity to work with the team and everyone on this committee. So with that, thank you, Mr. Chairman.
Absolutely. Madam Chair, we realized that while we worked pretty closely with Webb and team at MDA, there's a lot more work to do with the Dental Hygienists Association. So stay tuned. We'll be in touch soon, probably next
Okay,
week.
thank you, sir.
Yep. Thank you.
Ms. Reisberg?
Madam Chair, Director Brereton, Director Swanson, could you help me understand the outlook for Initiative 1 past year 1? Will other positions be considered for future years, or will the goals or metrics be just a continuation of year 1?
Commissioner, if you want to speak to Initiative 1, you can start. I'm also happy to weigh in. Your call.
Yeah, I'd love you to weigh in, Director. We right now have built our plan around the specific commitments assigned to us by DPHHS, but of course, if there's an availability to expand that to additional occupations, we would love to participate in that process.
Sure. So Sierra, thanks for the question. So the metrics that are established, the position types that have been identified under Initiative 1 are pretty set for all 5 years as of right now. But I think as we move into year 2, potentially move into year 3 with CMS, we may see a willingness from the federal government to be a bit more flexible to states on the healthcare workforce initiative front. Obviously, if we were to change course, we'd need to do so in strong partnership with Department of Labor and Industry. We may need to amend the MOU that's pending and will hopefully be executed soon. But at this time, what you see is what DLI is being held accountable for in the workforce space. But it is subject to change. It could change. I just don't know right now.
Thank you.
Mr. Brown, did you have another question?
Yeah, if I could please, that kind of prompted Sarah's question, kind of prompted a question for me too. So if Director, if all of the qualifications that we submitted, the commitments that we made are not met, is there a clawback provision per se from?
Glad you raised that, Webb. I was going to come back to this.
Please.
Yeah, so if Montana does not achieve certain milestones across all 5 initiatives that it committed to in its plan, what will happen is CMS will reduce the state's subsequent year award. So when we report on year 1, even though it wasn't a full year, but when we report on year 1, CMS will take a look at how did you do compared to what you told us you would do. And then they will adjust Montana's year 2 RHTP award accordingly. So it could be reduced as a result of deficiencies or failure to perform in year 1 in certain categories.
Chair Etchart, if I could follow up on that, I guess recognizing, I'm sure CMS recognizes that our legislature doesn't meet every year. So if some of those commitments are based on us getting something passed, for example, accepting the compact, we're out of luck. But I'm sure they would take that into consideration.
Yep. So we've been very clear with our CMS, RHTP program officer and CMS leadership that Montana's legislature is in every other year. And for some of those policy commitments, including the EMS compact, for example, we have until end of year 2027 to implement. And that was by design due to the department's flagging that the legislature is in session every other year. So we've been mindful of that.
Thank you, Chair Etchart.
Excellent. So we do need to make sure that we end today on time so that everyone can get ready for the next meeting at 2. So I just have one question for Commissioner Swanson. You mentioned the MOU, and I mean, you did discuss it pretty in depth, but what I want to know is what is the holdup with getting that MOU? It sounds to me like it really needs to get done. And also, what's the time frame for getting that done?
Thanks, Representative Etchart. I think we're close. There's one last topic being discussed between the two agencies so it can be finalized, and that is the funding allocation specifically for the training of emergency medical providers. I know our staff has met many times this week working through the budget components from the original RHTP proposals of what stakeholders recommended to DPHHS for EMS training and to where we are today. As soon as we finalize what that funding looks like, so we know how many dollars we have to train EMS professionals in Montana, I think we're ready to execute, but I would open it up to Director Brereton if there's more that I've missed.
I echo the commissioner. I think there's one other term that our teams are potentially negotiating on the legal side, but we're getting much closer. Madam Chair.
Excellent. And then one last question. You said EMS providers. So you're including not just the basic EMTs, because basic EMTs can't transport. They have significant restrictions with transporting. So you have to have EMTs that can transport and paramedics. So are you guys also including that in this discussion?
As I've currently seen it, Representative Etchart, the definition being used is emergency medical provider. So that does encompass all 4 licensed types of emergency medical providers in Montana. It also includes funding for those existing providers that want to obtain the community integrated health endorsement. As of now, there's no restriction on number of EMTs versus paramedics versus EMRs. But it's wide open for us, and that is the budget conversation that's happening. Because as you well know, the cost of training for an EMT versus a paramedic is very different. And so that's the conversation underway right now.
Excellent. So I really appreciate everyone's time here. So let's go move on to public comment. Director Brereton, did you have one more thing? I'm sorry. Please, pardon me, Director Brereton. Go ahead.
Thanks, Madam Chair. Before we moved on to public comment, I wanted to come back to Sierra's question. And I just want to ensure that I'm clear. We're not going to ask DLI to change course or, let's say in year 3, not make investments in the workforce categories or types that DLI is committing to right now, that DPHHS is asking DLI to commit to. But what may be possible, Sierra, is we receive additional RHTP money, and we would therefore be able to include other workforce types or categories, and then we would need to begin those negotiations with DLI. So I wanted to come back to that just to be really clear again that what we're asking DLI to do now, that's going to be for 5 years. We're not going to make a partial investment for 2 years and then change course. It's a waste of money. But there may be opportunities to provide the Department of Labor and Industry with more federal RHTP dollars in the future. And that would be incredible. We'll see what happens.
Excellent. Thank you, Director. Any more from Commissioner Swanson or Director Brereton before we move to public comment?
No, thank you.
Excellent. So public comment, if anyone in the public would like to comment, please raise your hand.
And Chair Etchart, if you wouldn't mind just reading that statement that's on the agenda while members of the public raise their hand, that would be great.
Excellent. The subcommittee now offers the public in attendance an opportunity to comment on any public matter under the jurisdiction of the subcommittee that is not on the current agenda. The subcommittee cannot act, but will listen to comments and may ask staff to place the issue on a future agenda. The chair may limit the comment period to precede the subcommittee meeting. Public commenters should state their first and last name when offering comments, and spell your last name as well, please. I don't see any hands raised for public comment. So in the interest of time, we'll have public commenters if they, we'll give them About another 30 seconds. Okay, I see no hands raised. We're going to move on to the integrating the work plan for going forward. Ms. Sullivan, take it over, please.
Okay, thank you. And thank you everybody who presented today and asked such great questions. So earlier this week, I emailed everybody the draft work plan for the healthcare subcommittee. And this is the work plan that the co-chairs will be presenting to the full task force on Monday. So we're going to need to do a little bit of a pivot and rework some of the meeting topics just to incorporate what you guys heard today and some of the asks from DPHHS, as well as maybe just a couple things that we aren't quite ready for. So if you want, I can put that document up. I think that would probably be the most helpful.
Yes, please. Thank you.
Okay, I will share my screen. So this is this was the this is the work plan. I went ahead and I added in the April 10th meeting, today's meeting, just so we can have it memorialized. So we are meeting again on Friday, and that's just in the interest of time to keep things moving along. Originally, we had scheduled the continuation of administrative burdens. Now, admittedly, I did go back and rewatch the March 13th meeting, and I forgot that we had agreed to continue forward and start on pathways to licensure. So my apologies for that, but there's a lot going on. So I have some information on interstate compacts prepared already, or can have them finalized for Friday. And so if it's okay with the committee, we can start on that topic, because that does play into some of this initiative one requests. And then I will also hope to have some follow-up data requests that were asked from the last meeting that we can just kind of review. But what I was thinking is that we had originally separated our work into just administrative burdens and pathways to licensure. And my original idea was to tackle the administrative burdens first and then move on completely to pathways to licensure. But I think what might be a better use of our time is if we kind of put administrative burdens not on hold, but just get some more data, do some more research, and then come back to it maybe in June. So move forward with the pathways to licensure and the RHTP issues. So as Director Brereton suggested, the what is it called? The CME for the nutrition. That could be a topic that we could put together for Friday, as well as interstate compacts. And then I don't know if there was anything else that is, I mean, it's in a week. And so if there's something else that's little that we can throw in there, we can certainly do that. Did you want to jump in, Director?
Yes, thank you, Aaron. Madam Chair, is that okay?
Please, please.
Okay. So for the EMS compact, I thought it may be helpful to have Sherry Graham on our team here at DPHHS bring a representative from the EMS compact before the subcommittee to present, but wanted to get the chair's thoughts and the subcommittee members' thoughts on that approach. And then we can come back to nutrition CME.
I think that would definitely be helpful. And then Ms. Sullivan, had you already discussed so that we're not duplicating there?
Yes, and so, and actually, I see Amy has her hand raised. So she had also offered to have somebody from the EMS compact come talk to the committee at some point. I don't think they were available for the 17th. And so we could do it two ways. We could just start the topic on compacts. If somebody is available, that's great. We can have all of that at once. Or we could start the topic and then continue it at the May meeting. Amy, I don't know if you want to jump in.
Ms. Nearson?
Thank you. Yep, I was just going to add, I had been in contact with the CMS or compact, sorry, EMS compact representative. He's traveling next Friday. He would love the opportunity just to present to the task force about the work that has already been done in the state and then the remaining steps in order to get the compact ready for the legislature. He is available on May 15th and has it on his calendar. If we can, if the committee would like to have him do that presentation on the 15th.
Thank you, Ms. Nearson. We'll just have you work with Director Brereton and Ms. Sullivan to make sure that that's covered adequately at the meetings with whomever you guys are bringing forward to get that done, and really appreciate everybody's work on that. Good job, guys.
Okay. So aside from the interstate compacts, again, that can be, and as I can't remember who asked, I think it was Kristen asked if there were other compacts and all of that, and there are. And like I said, I have a document that it's in comms right now, and so we're working on getting it looking nice and sharp for you guys. But it shows all of the compacts that Montana's not yet a part of, and so I think that can be just the beginning of the discussion. We don't necessarily just have to talk about the EMS compact on Friday. We can talk about all of them. And then we can do a segment on the CME for nutrition. And I, again, will work with DPHHS on coming up with some data or a speaker or somebody to kind of help out with that segment of it. Aside from those two things, and then just a review of the data follow-up from last meeting, does that sound like a heavy enough meeting for next Friday with everybody?
I think that sounds like that can adequately cover at least several hours, if not more. Director Brereton?
Thank you, Madam Chair. Erin, I would welcome this group's thoughts, including DLI's thoughts on who from the Board of Medical Examiners may want to join on the nutrition CME issue to help some of us better understand where we've been on this issue in the past, referring to CME broadly, beyond just the nutrition CME.
Okay.
Commissioner.
Director, you may not have seen it, but there is a note in the comments from Ms. Branscombe at MMA requesting a conversation from us. You have an email from me incoming, checking calendars to see if you can join that discussion on Tuesday.
Perfect.
And then our team can certainly work with the board and representatives from MMA to figure out who needs to be in this meeting on the 17th.
Sounds good. Thanks.
Okay. So then, does anybody have an opinion one way or another as far as kind of focusing on the RHTP stuff immediately and incorporating that into the pathways to licensure discussion and everything that's already in the work plan, and then coming back to the administrative burdens, probably in the June meeting?
This is Tony King. I think that makes sense. It's top of mind, so let's take care of it.
Okay, great. And I think that will help because there is, I know, and I just talked with Stacy earlier, like right before this meeting, because she had requested kind of a survey of the group on some specific licensee barrier information, data collecting, and I completely forgot about it, to be honest, and I apologize. But that's something that I could put together and then kind of put out, and we can have kind of prepped for either probably the June meeting. And so we can, focus on the pathways and getting those ideas all put together, and then come back to the discussions that we had last meeting about the boards and the licensees and barriers and administrative burdens, and kind of wrap up. Actually, we won't be wrapping up in June, but working towards wrapping up on those topics in June. Okay. I think I have what I need to kind of revise this work plan for the co-chairs. Rep Etchart, do you have anything you want to add? Or Tony?
Not for me, no.
Okay.
Just kind of what we discussed before, and something that was brought up least I think it was brought up today. We brought up community health workers, and I think Senator Small brought that up, community health workers, making sure that's under DLI, making sure everything's under DLI. And then at some point in the conversation, I don't remember today or other, but CNAs, I don't know if CNAs are under DPHHS or DLI, but it almost stands to reason with all this so that DLI can take care of everything in one place to make sure that CNAs are all covered in one spot. And then, of course, that I brought this up before, making sure that our rules and regulations and the arms are consistent with being able to hire people, and that there are minimal, if any, barriers in any arms. So make sure we're looking at regulations. And like I said, I've discussed that before. I think that's part of the work plan going forward, but just to make a reminder of that.
Okay. Yeah, so I think a lot of that is kind of administrative. And so that all of that we can pull some more research and topics for discussion together to circle back to in June.
Perfect.
Yeah.
Thank you, everyone, for the meeting today. Does any Commissioner Swanson?
Thank you, Representative Etchart. I do have one final question. Aaron Sullivan is going to be sharing with all of you as part of the meeting materials the current draft as it stands of the parking lot, if you will, of issues that may fall outside the boundaries of this task force, but are important to all of you. As we're thinking through, the finalization of this committee's work this fall, and next steps for the legislature, I'd like to make sure we've captured all the parking lot issues from all of you. So before we meet again in person, if you wouldn't mind taking a look at that and come prepared to our next meeting to share with us if there are other parking lot issues related to licensure, I'd like to make sure that document is complete as we can be as we continue to move forward.
Thank you. I will get that out as soon as I can this afternoon.
Thank you. And Director Brereton?
Madam Chair, thanks. Before we wrap up, I just wanted to thank Erin Sullivan for her responsiveness and all of her hard work for all of us. It's been incredible. So thanks, Erin. Appreciate you.
Thank you.
Senator Noland.
Thank you. I just wanted to ask the commissioner, has she been receiving a lot of other oddball questions like I ask her all the time, or is it just me?
It's just you, Senator.
Great question, Senator. You are certainly not an oddball. Your questions are always welcome. But the task force has created an opportunity for so many Montanans, whether they hold a license, represent licensees at an association, or just use the licensing system. As a consumer, lots of people are asking questions. My inbox is quite full, as is Erin's and the rest of our team. But I think we've done a great job through Erin of kind of catalyzing all of that into the work plan and putting the outlier issues, if you will, on the parking lot. And we're moving towards some good conclusion. So thank you.
Thank you all.
Senator Noland, you have such huge expertise and institutional knowledge with this. Your questions are always welcome. So do you have anything else to add?
No, and I can't figure out how to shut my phone off with raising my hand. So my hand's down.
No worries, Senator. We really appreciate you. Thank you so much. Does anybody else have any other comments? Okay. Thank you so much, everyone. Meeting adjourned.
Thank you.
Thank you all.